is representing Dr. Michelle Morse in a voting capacity. I would like to propose a motion to adopt the minutes of the Strategic Planning Committee meeting held on June 10th, 2024. All in favor, please say yes.
Yes.
Opposed, say no. So minutes are adopted. Next, we will hear from Ms. Brown, Mr. Stigley, and Dr. Way as they provide an update on the system dashboard.
All right. So unfortunately, Matt could not be here today. So Deb, Yvette, and I are carrying the load today. So I'm going to start by handing it over to Deb to give our governmental affairs overview.
Good morning. Nice to see everyone. Could we progress just the next slide? Thank you. This is the time of year, as I think you appreciate, where we're sort of actively planning, I would say, on all levels, right? So even though technically neither the city nor the state budget process have begun, we are very actively engaged, putting forth our priorities, both financially and presumably legislatively on the state side, in this what might be a dormant period otherwise. As you probably know, the cycle is really from September to August. So poor Michelle DeVacco in Albany, who used to have more of a break and does not anymore. So that's really where we are. On the federal side, as we come to the administration, we continue to advance our priorities, specifically DISH funding. That is, as I always say, the beginning and the end of our federal advocacy, and we'll continue to do so. We continue to be very engaged with the delegation. We'll be down there again in December. Senator Schumer, who is an incredible proponent of hospitals and on DISH funding, has been very vocal in his support for DISH, and his reassurance that we will not be harmed. Nonetheless, we continue to push because it's the right thing to do. And we continue to focus on things like telehealth, health flexibility, hospital at home, a few other things like that really were born out of the COVID crisis and have been advantageous not just to us, but to our patients. Those are our priorities.
Questions?
Right now, the DISH funding is scheduled to start, cuts are start
Yeah.
in December, is that?
Well, January, but yeah.
So we're waiting for a extension.
Yeah, I mean, so you might recall what we do every year, frankly, around this time, sometimes it's every other year, is it is effectively kicked down the road. And so what we would really like is for the DISH cuts to be eliminated altogether, and if not, to continue to be postponed.
Any other questions or comments?
Then let's move on to the debt system dashboard and the trends for Q1. So, per usual, we're going to start with those that are positive trends and beating the targets. And just a footnote, we did revise some of the targets. So as you look through the slide deck, the ones that say revised targets are the ones that were changed because we've already consistently met the previous target. And so first, the post-acute care all-cause hospitalization rate did decrease from 2 per 1,000 care days to 1.8. We're still trying to get to the target of 1.6 here. I know Coy and his post-acute team are working very hard to do as much treat in place as possible. If a resident falls, to have that resident evaluated by a provider there before calling 911 to have an ambulance come and transport to the hospital. A lot of focus on chronic care management as well. I know his team is exploring telemedicine to kind of expand capacity both for the routine provider care as well as with these falls and emergencies. The second that continues to keep going up and up is the hemoglobin A1C control under 8. Has gone up from 67.8% to 68.8%. So each quarter it feels like it's a record. This target was revised to 69% in conjunction with Nicola and the Pop Health team. Percent left without being seen in the emergency department went down from 4.7 to 4.4. I think this is just common cause variation here. It's still above the target of 4.0, but I think if you look at the before and after volumes for our EDs before COVID and after COVID, it's incredible what the teams are doing just to keep it in this 4% range. Moving on to the next slide, financial sustainability. I don't know, Jim, do you want to cover those?
Sure. In terms of financial sustainability, the first one we increased from 71 to 77%. It is below our target of 90%, which is certainly a very aggressive target. And I think that, you know, when we saw that dip to 71 and even what you're seeing in the 77%, we were trying to clear some old cases and things like that. So we expect this to continue to tick up, and, you know, we hope to get close to that aggressive 90%. In terms of the total AR days, that's at 54, which again is down quite a bit, still above the target of 45 days. What we're really seeing here is the continued impact of the Change Healthcare outage. So, you know, that sort of caused an overall blip, especially to that 64 days, and we're still kind of recovering and coming down. So this should continue to come down, and we really do want to get back closer to that 45-day, which we were pretty close to, but hadn't quite gotten there prior to Change Healthcare.
And then the last one is a new metric here. Unprint is a new 5-year initiative being led by our CIO, Kim Mendez. And the idea is to reduce printing, especially color printing, and look for alternative ways, such as iPads, iPhones, or just not making copies for everyone in the room that they immediately throw away when they get back to their office. And so,
We're really feeling very shamed right now. Yes.
I printed it out too, but not in color and on both sides. And so
Oh, yeah.
the first,
Let's go both sides.
so the first step was creating kind of a 5-year QI plan and looking at the data, you know, which starting with central office, which departments or offices are utilizing a high amount, and then we're going to go to the facilities. We know HIM, you know, when someone comes and asks for medical records, they just print it all, right? And so you can imagine some of our patients have quite extensive volumes of medical records. Other things we're looking at is even within Epic, you know, the after visit summaries. Are there ways that a patient can opt to get it on my chart rather than having it printed out and once again throwing it in the trash can in the lobby on their way out of the hospital? But this is similar to kind of our prior EITS metrics that will present a percentage on track on this 5-year goal here. So right now it's 100% for this prelim phase. Sure. Do you have a question?
On that, is it just sort of you have a can't think of a word, but
Target reduction.
do you actually have percentages reductions, or this is just milestones of actions?
I think this is just milestones to start, but eventually we will get to the actual reduction. I think this was triggered by Dr. Katz noticing a big number the last time the board
It was huge.
Of printing costs.
The huge printing costs, right? Just like crazy how much it costs us to print.
Yeah. So eventually, this will translate into
the outcome measure there. Yep.
Reduced printing for environmental purposes, and also reduced cost for financial.
That's the goal, right? The sustainability piece is the focus, not the cost savings. The cost savings is an added benefit.
Yeah.
That's we need to play our part.
And it's so easy to achieve, right? If we would just stop printing color,
right?
That in and of itself is huge, right?
Color and double-sided would help.
Double-sided, of course, helps paper, but it doesn't change your printing costs or the toner costs. And the environmental part is actually the toner that's so bad for the environment. And, unless you're doing advertisements, I'm not really sure why we have to have color. So we're trying to move away from color printing.
Deb had an early win together with Mitch. Is that bar at the bottom that you guys used to see of H plus H plus H?
Yeah, it's
The
gone.
color, that's gone.
Yes.
That was incredibly expensive for us. And I mean, again, there is a purpose for that on a bus shelter, on a poster, right, on the, something
not
that
every
you're,
page will
but
be-
not every page that we're distributing to each other.
Right.
Right, there's no value in that, and, you know, just to point, you know, if you print, you know, and again, like, this
Could be black and white.
should be black and white ideally.
Right.
Right. So, but, you know, we have to change all the templates, right, but we don't need this in color,
Oh, we could just print that in black and white.
right, yes, yeah, we will. But I'm sure like this comes from a template that was created for Coalicia to do this. So then that's what we're doing. We're gonna go back and change all the templates so that it will just automatically print for us in black and white, which is perfectly fine. We don't need the yellow and the blue and the light blue for ourselves.
Since we're on this page, could I ask,
Sure.
on the AR days note, there's a note here that says legacy AR is still included in this metric and the calculation will be modified to include Epic only. Does that mean those are just write-off? The legacy AR, we just are, I wasn't sure what the significance of.
Yeah, so by and large, I think the legacy systems were more meaningful before kind of Epic was fully implemented, and we sort of still had kind of active cases. Now I think it's been 3+ years since really the legacy systems have been utilized, and so any sort of leftover AR from that, I think we want to take a look at and see how does it, you know, is there really any focus on it still? Should we just kind of write it off to your point? But I think from this metrics perspective, it's much more important and much more meaningful to just track our Epic performance, because that's really what we're actively working on, including, as you know, with the no claim.
So do you think that will change our target, or
It could potentially bring our target down. I think we want to see, as we come out of change and as we now pull the legacy systems out, what that'll, you know, how that impact has, and is it worth changing our target when we look at Epic alone? But
okay, yeah, so it seems like there's a lot of noise right now, given the
Yes.
Change Healthcare and, you know, how far off we got.
exactly. But yeah, we think the legacy system will be a more meaningful statistic, and if it helps bring our target down, we would certainly do that.
Okay.
I have
go
a
ahead.
question about the financial assistance and insurance coverage. So it says in the note, and I think you talked about this, that there was decline in staffing and then there's increase in patient volumes. And I'm thinking from the QAPI meetings, I think there was a big push, right, to get more people into financial assistance that wasn't necessarily related to insurance, or were they both, are they exactly the same?
I mean, that's
They're not, right? I think they're separate or overlapping.
financial screening. The goal is to
Right.
get to over 90%, right? Or 100%, and then get the percent of uninsured patients either into
Okay.
Medicaid, the exchange,
Got it.
or NYC care, right? And so we did take a hit on the front desk staffing for these financial screenings, so they weren't able to get to 100%, and we have been able to hire up since then, and so now we're seeing all these numbers go up. But this one is an outcome of that financial screening.
Oh, okay, I got it. So it's not just, so it's not, when it says enrolled in financial assistance, is there something other than, I think there's probably something other than insurance that they could be
NYC
enrolled in.
care.
Got it, okay, sorry, I wasn't sure what that, all right. And then, this is you have front desk staff at all locations? Like, what's the staff? I'm just curious, like, is it 2 or 3 people
No,
for
it's,
each
it's,
hospital? Like, I
no,
don't
it's,
know.
it's much larger than, I don't know exactly but it just depends on what the kind of outpatient volume, the inpatient volume is. But we could get back with the exact staffing model.
But do you think you're at the right staffing model, or are you still?
I think we're still a little bit, I don't know, you bet, do
Under?
you know? We're,
I think we're bettering the staffing model right now.
Yeah, I think we're getting there.
You're getting there.
And the key thing is we're trying to do as many touches as we can before the patient even comes in, so that the
And
work's done on the front
is
end.
it that you have the lines, but maybe you just don't have enough people that are hired, or they leave, or,
Yvette, are you saying that we're better than the staffing model? Like we're
yeah, like, I don't know what that means.
higher?
I think we are better right now in the staffing model. I think that we've had a very good recruitment year,
Okay.
and so we have to continue though to monitor.
Maintain it, okay. So maybe you've caught up to like, okay, you've got the right number of people per like number of patients you need, but
Yeah.
it could drop off if, 3 people leave.
Yeah, yeah.
Okay.
No, we kind of shudder at the previous, some of the stories that we heard where if it got too busy, they just started waving people through registration. Now we just, you're right, want to make sure that we're not skipping steps.
Okay. And what's the staff, like, what kind of staff, like, what staff, like, what kind of staff are they? Are they clerical, or are they,
The clerical that does the registration?
yeah,
Yes.
and then the counselors are certified counselor, like, what's the,
The HCI counselors
Yeah.
at the hospital, those are under finance and they are specialized.
okay. All right, thanks.
We'll go to the next slide. So this one is one that you'll see a sort of an upward jump here. If you look at the footnote, it is a change in definition with this data point. And so we were crushing it with MyChart activations when everyone needed to sign up for MyChart to see their COVID test results. But what we realized is, when that incentive sort of went away, we saw the slow kind of trickling down. But the ones that we really care about are those who are impaneled to our primary care, right? These are our patients that we want continuous communication between the PCP and the care team with. And so we revised this metric to just be amongst patients impaneled to H&H primary care. And so that's why it's jumped up from, I think it was in the low 70s to 82.4, which is up from 81.1 using this new definition. And the revised target was also moved upward to 84%. Access to care, unique primary care patients, we still are seeing a nice upward trend there, 447,000, up from 440, a little bit below our new revised target of 450,000. Same thing with NYC Care, it's gone up about 3,000 to 149, and the revised target here is 150,000. I know Ted, Jonathan, and team are really leveraging community-based organizations as partners to help continue to enroll eligible folks in NYC Care across all of our boroughs
And,
here.
and we're doing a refresh on some of the communications and branding to try to hit people in ways where we might not have gotten them before, and so you'll be seeing that in the coming months and then into the new year.
And what's the note here on NYC Care and the over 65? What
Yeah.
is, I'm not familiar with that.
Do you want to take it?
Yep, go ahead.
So, state is now allowing over 65 people without documentation to be enrolled in insurance, and so we're gonna see presumably potentially a decrease in NYC Care, because people will not need it, they will be able to have an insurance product.
So they won't be asked for, I actually don't
Yeah,
even
they
know.
will be. I mean, so it's a screening process, and then whatever is the appropriate avenue for the individual patient is how they are directed.
I mean, the goal is still
Remember,
to
NYC
yeah.
Care is not an insurance product.
No,
It's
I know, but
access.
for them to be able to get the insurance,
Yeah.
it'll be, I guess what I'm asking is there a way that they could be easily discovered in the environment that's coming?
I mean,
As they go on to insure, like, I don't know what the like, when you're over 65 and you're going, I guess on Medicare or whatever, haven't done it yet, I'm assuming I don't know if they ask for Social Security, I don't know how it works, but I guess I'm just thinking, like, is the state gonna be able to protect that?
Yeah, well, I think maybe these are great questions and important questions, so maybe we'll kind of
Yeah.
figure out a way to provide that information. Which, and again, they're terrific questions.
I'll take it as a follow-up.
And I have another one.
Yep.
See, I've never come to one of these, so you're punishing them for having me come for quorum.
We're happy to have
And I've asked you about this before, I think, with the MyChart activation. Are you able to look to see if the activation level is the same by preferred language? This is one of those things where, like, you've talked about how, like, okay, you have the educational videos in the other languages, which is great, but, like, I'm still thinking, okay, if I only speak Spanish, and I go to my doctor and they say, okay, you need to sign up for my chart. What am I gonna see? Am I gonna get a text that's in Spanish? Is it gonna come to me in English? I don't know how this works. And again, maybe this is too much for today, but I am
I
just
mean, we know
curious.
we know the big picture. We know that we have Spanish and Chinese
On my chart, I'm not sure.
on the
I know definitely Spanish.
definitely Spanish. I think also Chinese
Mandarin,
now.
yeah.
On the computer version,
The actual
not the
phone.
phone version.
Ah,
The Epic has not created that yet for the phone version, but on the computer, you can have the whole My Chart
Okay.
in Spanish.
great.
But on your phone, you cannot.
And then what about the communications that go to people? Are they in that preferred language, or you know how like, the My Chart thing, like once you sign up and then the, admin back end, it ends
Yep.
up like, a lot of times you get this thing that comes to email, it's like English.
Yeah.
Is that also translated?
I don't know about the text messaging or emails, but I do know on your AVS, it does come
Okay.
out in the language that you select.
I mean, that's
And
like
my
an
patients
yeah.
do use My Chart to send me messages in Spanish.
Okay, so then they
Um,
just,
So,
Mitch, but if the doctor puts notes in English, does that get translated?
in the Spanish version, it would, yes. The
but you said
Spanish
it's the
version
after visit
translates
summary,
everything.
but not the
No,
notes.
no, I think the notes, you would have to get an actual translator.
Translate, you'd have to
Oh,
copy,
yeah, I guess you're right.
or you could copy it and
Right.
just have like Google translate it for you.
We're not supposed to do that.
I know, no, I'm saying the patient could do that.
Yeah, no,
Like
absolutely,
if
yeah.
if they were like, I wanna
Yeah.
see the notes, because the after visit summary has almost nothing in
Right.
it, no offense, that's not your problem, that's a system problem. Okay, interesting, we still have, and Epic is engaged in, like, they're good, or do they need like more push?
I mean,
You know we like being pushy at the health.
Yeah, I
department.
think if you ask Ivalise and our team, working on interpretation services, Epic's not moving as fast as we had hoped, but they definitely have increased the number of languages
Okay,
that Epic is in. I think part of that is also globalization, right? Like as
yeah,
countries sign up for Epic, they need to
get with the program.
program it, right? But
Okay.
no, I think they are taking it seriously, and
Okay, I mean, not that we have much power, but if it's a thing, no, I mean, if it's a thing, then it's like, I don't know if there's opportunities that come up in comments, but like, it can just be something we pay more attention to.
Yeah.
Okay,
okay. On the next page, on 14, these are stable trends. And so quality and outcomes, follow-up appointments 30 days after PH discharge stayed about the same, down to 62.3 from 62.9. The target is 65%. This is one that I know a lot of attention is paid on by Omar and the OBH team, and the biggest thing is getting community health workers actually escort discharged patients out, and that conversation that they're having while they're going out can count as this follow-up appointment. Telemedicine is another way that we're trying to bring this number up. On care experience, ambulatory care experience, recommend provider office, 87.4, down from 87.9. This is a revised target, and I think it shows how advanced we're getting with our analytics, that we're going to 2 decimal places.
I was gonna ask about that.
88.39% is the revised target on this one. But we think this one is right, just common cause variation, only change 0.5%. The culture of safety, total wellness encounters, which is a reminder, is one-on-one debriefs, group debriefs, as well as wellness events, 2,047, down slightly from 2,070. The revised target is 1,500 here.
Eric,
Yes.
on that, the wellness encounters, sometimes I think about, is it good or bad to be over? So the revised target is up? Or
Revised target is up. I think initially it was a concern about of resources, right? Do we have enough H3 leads, wellness directors, and so forth to be able to maintain it? I think we're at a pretty steady state now. Post-COVID, it was much higher demand, and even that period right after COVID, a lot of demand. Now it's, right, we have events all over the globe that are affecting our staff, and I know there was a lot of activity after the November elections. Um, and so I think this is pretty much our steady state. So some
Like
ups and
2,000-ish,
ish,
but our
yeah.
target is,
At least 500, at least 1,500, yeah.
right.
Yeah.
So, I mean,
More is better.
more is better, or are we getting concerned if it starts to,
I think
really?
we'll get concerned if like there's a huge spike.
Yeah,
But I think, right, as we are investing in wellness in the system, whereas before it was kind of an extra role responsibility.
Right.
It's like the social work lead was also the H3 lead,
Yeah.
right? Now we have two chief wellness officers across the system, Elmhurst and Kings. Everybody has a wellness director, and some of the CEOs have actually put staff under them as well. And so these are people whose full-time job is to support the staff.
right. Okay.
So with that, we expect more activity.
Yeah.
I think is unmet demand before that.
And is there a way to track, say, unmet need, right? This is a
I
hard
think-
metric to,
yeah.
because there's the question.
A lot of it we cover, and I don't know, Como, you want to come to the table and talk about our employee feedback survey and some of the wellness metrics that we track. So we do it every other year employee feedback survey, and so some of it is around burnout, wellness, stress level, and so that's kind of what tells us big picture.
Hi everyone, good morning. I'm Komal Lodaria. I serve as the Senior Director for Care Experience, and my supervisor is the System Chief Wellness Officer. So just speaking to the wellness encounters that you are looking at, I would say that the encounters comprise of debriefs, which are one-on-one or group, as well as events and rounds. So the more proactive we are, which is events and rounds, it's a good thing that the number is going up. The idea is that we want to keep more of a check and balance around debriefs, because those might have to do with more specific events that might be maybe more stressful or sort of negatively impacting the workforce's wellness, well-being, and resilience. In relation to the employee feedback survey, every other year we ask questions about experiences of burnout, compassion fatigue, stress, feelings of sadness, anxiety, etc. Over the last 2 cycles of surveying, we've seen a drop on average in the percentage of staff reporting that they're feeling burnout and they cannot sort of control it, or they need sort of a more serious sort of level of support. Which is a good thing. So more people are moving away from reporting that they are completely burnt out, and more in the realm of they might experience some symptoms, but they have a grasp on how to sort of manage that for themselves. I think in terms of stress, anxiety, there's a little more variation. We're not seeing sort of a consistent or stable trend, but happy to answer any other questions around that.
I think what was encouraging is that of all the metrics, they all moved in the right direction between the last one that we did in 23 compared to 21, and the one except for one that stayed the same. And it also awareness about Helping Healers Heal services and willingness to use Helping Healers Heal services went up, and so that's kind of encouraging that we're moving in the right direction
Right.
and closing that gap.
That's good. I mean, it just was, it sounds like there's a lot more data behind this than just the number of encounters, and so I think that's very helpful to have that context, because otherwise it's, what's the, I don't know what the right target is and what the meaning is if we're exceeding that target. The second question I had is on the employee survey. Is there any thought of maybe doing that annually instead of every other year?
Yeah, it was a big discussion. A lot of work goes into just administering it because
do
you
that
have to track.
internally
We do
ourselves?
that internally with Press Ganey as our partner on it, but it also takes time to go and analyze the data. So Como and Jeremy and team have done a great job of not just like, oh, box checking exercise, we did the employee feedback survey, here's your results, right? It's actually sitting down with the CEOs and be like, these are the units that are red zone units. Like they're clearly, distressed, how are we going to, wrap our arms around them, provide support to do quality improvement projects to improve well-being in those units. Um, and it takes time to do those things, right? So it might take almost like that first year just to like put the plan together so we wouldn't see results. And so we wanted to make sure that there was enough time in between, that we're not discouraging the
And
staff.
that survey is directed just towards wellness of,
It's we've because of survey fatigue. So that's the other conversation, right? There's a nursing survey. There's a AHRQ patient safety survey. We've tried to
It's a
roll.
compliance survey that was in our
Surveys,
prior
right.
meeting.
So it's basically right. We've taken 3 surveys and wrapped it into one that we're doing every other year,
Right.
and then there's kind of pulse checks in between. But just right, I think we had response rates like 18%, 20%, right? Like, and if you're doing it so often that the staff are like, well, nothing ever happens, and, right,
yeah.
they're feeling over surveyed.
We get surveyed and compliance trained very frequently.
So now we've seen like we've gotten like 40+% response, so more than double.
That's great.
Some hospitals are actually over 50, so it's great.
I think when people see some action coming out, like if you can tie changes and things that you're doing in response to surveys, it makes people want to participate
Yeah.
in the survey.
Yeah, absolutely. And so
And
that's what
do
we're
people
trying to
see
show
the-
them with the.
And do people see the results after, like, I know we get them, and I'm always like, wait, what do we look like from 2 years
Right.
ago? And then I have to go back into my email.
Yeah, yeah.
Is there like a visual so that people
It
can
is.
see? Okay, that's.
So like while I was interim CEO at Lincoln, I kind of dropped in the middle of this process, but there's what we call the quad. It's the lead for HR, patient safety, well-being, and care experience. Of course, care experience. Are meeting together with unit leadership, multidisciplinary leadership, together with the CEO. And so we go over all the results and then like brainstorm together. Some actually came and be like, I really studied my results and these are my ideas. These are the 5 actions that I'm going to take, right? And many of the managers are engaging their teams, right? Like, these are the results. Do we agree with them? What do we want to do about it? And so this never happened
Yeah.
before, right? It was just kind of like, right, here's a report card.
Right, right. Thank you.
Okay. So on page 15, stable trends continued, the financial sustainability.
So I think both of these metrics stayed exactly the same. So our patient care revenue of expenses still at about 78%, which is really great. And you may note that we revised the target up quite a bit. So it had been at 65%. We raised it all the way to 75%, which we think should be our new normal. I think we're going to continue to evaluate it as we, think about our patient care and supplemental Medicaid revenue strategies. But we think this is a good post-COVID,
Oh, good.
kind of noise.
Well, I know we were
place.
reluctant to raise the target too quickly because of the financial nuances of COVID funding, so
Yeah.
that's good.
But we feel good, and this is a place we want to stay at.
Right.
Of course, if not exceed. And then with the Metro Plus spend, that still remains a little bit below target at about 40.6% against the 45% target. This is actually a metric we're going to revisit and adjust for future quarters, with the focus actually being a 12-month rolling average with Metro Plus as opposed to a quarter at a time. A big reason for that is that you don't actually have the claims run out time. When you're only looking back 1 quarter, it usually takes longer for the claims to mature. And so this sort of had become a slightly misleading metric / it wasn't telling the full story. So we think this rolling 12-month will tell a better story. And I think, as with some of the other things, we'll revisit if the target should change as we implement the new methodology.
So do you think by doing that, the percentage of spend at H&H would be higher?
Not necessarily. It may stay similar. I think the bigger thought is that it'll tell a more helpful story because I think we're
In terms of trajectory, you mean, or?
in terms of trajectory, as well as, I think there's a question of like who got paid first before. So like which claims Metro Plus got to first. When we looked at this metric, it said, oh, this is a number which at times may have been advantageous to us. At other times, they may have been prioritizing other providers, and so it wasn't really telling something coherent, and sort of blips that you saw or changes were really that they were blips, and so this should give us a clearer trajectory and something easier to.
Smooths it out, the timing.
But and of course we would love to pull this up as I think Matt always says. There's that balance between wanting to make sure we have the access and availability of a network that makes Metro Plus a compelling health plan, while also trying to keep the spend that should stay within health and hospitals there. So that's another piece of the target we want to look at, is what is that perfect balance.
Okay, and then on the access to care metric, percent occupancy across our acute hospitals remained about the same at 73.7, up from 73.6. I know we discussed this at each meeting. You know, when we say our hospitals are full, we're talking about ICUs and med-surg, but there are pediatric floors, women's health floors, right? There are beds, rehab beds, that aren't necessarily 100 or over 100%. But we do have, right, occupancy of med-surg and ICUs that are 99, 100% across the system. Moving on to page 16, these are downward trends. So care experience, inpatient care overall rating dropped to 66.1 from 68.4. The target is 66.3. I think a lot of these have to do with increased volume, which is leading to more boarding in the emergency department. So you're admitted to the hospital, you might have to wait a day or two to even move upstairs, and it just sends that rest of that visit off on the wrong foot for patients. And so working on decreasing length of stay, moving patients to skilled nursing facilities, a lot of that work we're doubling down on, because we just can't build any more beds in some of our landlocked hospitals. And so we'll see the experience improve as the flow through the patient through the hospitals improve as well. On access to care, the number of e-consults dropped a little bit, 105,812, down from 113,000. The target is 95,000 here. We just had a wonderful update presentation from Hannah Jackson on Ted Long's team in ambulatory care about how what we've learned from our experience with eConsult. It was not exactly the same as LA's experience, and what we're going to do differently. So there's a lot of work on optimizing it. But the idea is that even with some of these optimizations, down is better for us, right? Mitch often talks about, right, he just has to ask the question once to the specialist, he gets the answer. The next 20 patients that have the same thing, he doesn't have to do an e-consult for each of those. We're also doing a lot of work of mapping together with all the specialists what truly needs to be a e-consult, what resources can we just post on the intranet that gives people the answers, who do I have to refer this to, what tests do I have to get before they go see the specialist, and all of those things we expect to decrease the demand for e-consult, but that's the balance with getting people to utilize it rather than just schedule or put in a referral. So there's a balance there, but with the optimizations, we wouldn't be surprised if it went down further.
I've gotten the first advice emails back now. The first time that, like in LA, I got back a response as opposed to patient scheduled.
Yeah. Good. Okay. And then our racial and social equity measure, the percent of new physician hires being underrepresented minorities in medicine, URM. This is still a little frustrating to all of us because the unknown is so high. It actually went up from 41.7% to 47.5%. So we're working with all of our affiliates, PAGNI, Mount Sinai, NYU, to try to do the data governance to make sure that we can actually get meaningful data here. The other caveat for anything that's not the July to September quarter, the number of hires is much smaller, right? So everyone graduates fellowship and residency in end of June, and so, right, last year, for example, in July to September of '24, we had 648 new hires, whereas April to June, it was only 211. And so some of these are harder to compare, right, because the end is so different quarter to quarter. But we did see an increase in women physicians, July to September, 46.5, up from 40. We saw a slight increase in Asian from 19 to 21, but a decrease in Black or African American from 7.1 to 5.2, Hispanic or Latino 40.7 to 2.9. And so this is something that it's hard to really tell what it means if 40+% is unknown. But we'll keep working to make this more meaningful.
I have a question. Is that unknown because it's missing or unknown because people put other, or it was another category?
I think it's a combination of both.
So what are the categories that you use? Do you use like the very detailed ones, or do you use the sort of standard OMB, which are very limited? Actually, this doesn't look like standard OMB, so I don't know what the category scheme is here.
We use these categories.
Just these.
Yes, and they're reported to federal and state. These are categories that we need to report to other entities. We think that it's really a matter of time that employees like to disclose their ethnicity. Sometimes they just see it as, it's not a significant data. And so human resources typically will send a message to the employee to say, please look at your data, update your data, and see if we get more of a response. Over time, the data usually increases in terms of that particular identifying factor.
I mean, you might want to just show, you might want to look at your missing. I mean, just so you know, like if I looked at this, I would actually go into unknown. You don't have my category here. And DCAS does not actually have my category either. So actually, I don't have a race ethnicity reported in my NICAPs, which has been an ongoing problem. It's not like my personal problem, but it's a problem in general because if the categories don't speak to people, they will not complete it. And so they just get tired of seeing too many limited categories. So who controls what the categories are? Who tells you what they have to be?
Well, I think it's the federal and state that will tell you what it is. So adding an additional category, I don't think it'll harm anything. It just when you submit it to the state or federal, it rolls up into an unknown ethnicity. So I don't think it harms us if the affiliate were to add either a free text. I mean, I don't know if they have a capability of doing that, but if they were able to add additional categories, I'm not sure it would harm anything that they're reporting.
Okay, so that's actually super confusing because if these are the only categories that people can check because that's what's considered underrepresented, which is fine, then the 41% isn't really unknown. I'm just not in one of those categories. So I think there's like there's something.
Or folks are choosing not to.
Right, but I think this is like it's very possible that half of those 41% are some other minority that's not in this list.
It's possible.
So there's something off with this. I don't know how to interpret I don't know what that means. I guess it's just as you're telling me this, I don't look at this as like this is a disaster because I don't actually know what the questionnaire looks like. Yeah. So I mean,
I think we've done some of this with our patient. Race and ethnicity has actually gone to I think we expanded by over 200.
Oh yeah, you have the whole list. Yeah.
Ethnicities. I don't think that's what our new hire providers are choosing from there, but we definitely can take a look. And also just like it's a melting pot, right? Like, like what do my children pick?
Right, but I'm saying it may not be that it, like when I hear unknown, it implies like someone just didn't respond, which is different than I'm in another category. It just doesn't happen to be the category of interest, which is fine. That's okay too. I'm just saying this is not easy for me to interpret whether this is a problem or not.
Yeah.
Because you don't know how many of the people just
Didn't
didn't do
answer.
it because they're like, well, I'm not in that category. And that's okay, because these are the only categories that you care about, although I don't know who's decided that those are the only categories. Where does, you said that comes from the state?
It could be federal and state.
There's something about this is, I'm
Well,
gonna
so
go.
it seems
yeah.
like, as a starter, it would be better if where we say unknown, what we really mean is unknown, other, I'm trying to think what else.
Just didn't
would-
respond, you know, it's
didn't
like,
respond.
right, like, I mean, yeah,
Right.
because
Right.
otherwise you just don't know.
And then the other part would be to go to affiliates and ask that they adopt a broader set of categories that would result, right. I mean, I do think and Shadi, you know this data better than anyone, more and more Americans do not singly
Yeah.
identify. Right, they identify as more than one thing. And the world hasn't figured out, that's yet another complication on how do you, is that, I mean, I think now the way people do it is they can check mixed, but mixed is not a very helpful category, right? And I don't think the world has really advanced to allow, I mean, really, you should be allowed to specifically check more than one thing that you are, if that's how you identify. But that's yet another problem that will get bigger and bigger as more and more people identify as more than one ethnic group.
Well, but for the purposes, I think the reason you're tracking this is you're thinking about
All right.
clinician concordance, right? And how patients are
Yep,
experiencing,
concordance,
that's a piece of it,
diversity, yeah.
right? So if you actually went to that option, which is people can check whatever it is,
And
and
more
then
than one.
and then you could end up having the percentages that are over 100%, but that's okay, because people, you know, if you're of 3 races, you may have that intersectionality, right? Like, to the point of why you're doing this metric, it's probably okay. Anyway, I could spend 100 years on this, but I guess what I'm trying to tell you is your response of like, oh, that 41%, I'm like, I don't know.
Yeah.
It could be that 30% of that is really people who are multiracial or another race, and that's okay.
Yep.
Anyway, just food for thought. Although it sounds like you're dictated to some degree from a federal or state, I don't really actually understand this. How is it both? You have requirements for both? I don't know where these categories are coming from. You said it was federal.
We have requirements for both, and usually they align. But we can, internally, we can decide to broaden categories.
But they're required from, like, is it CMS? I'm sorry, I don't know the regulatory.
It's probably Department of Labor.
Huh.
So we can definitely look into it further.
I mean, it's interesting because OMB has these very, like, there's a whole process where they're going to update it. Anyway, okay, more for later. Sorry, you thought that was going to be an easy one.
Those
I
are
hope
great,
this one's
those are
the
great
easy one.
points.
Yeah.
The idea of patient-physician concordance and
I think that's a
things like
piece of
that,
it,
it's
right?
That's a piece of it, yep.
it's a-
Right? So it's like, it's okay if somebody says, well, I'm 3 races, because somebody's going to look at them and,
Yeah.
if they're, I think we usually say like multiracial, but yeah.
Maybe we can look at, I mean, best practices for large employers that go beyond the compliance side of things on this.
Don't look at DCAS. I have been very angry about this for 3 years.
How that would look like.
Having this conversation because my 8-year-old is just asking me, like, when she has children, are they going to be 25% Taiwanese or 25% Persian? I'm like, that depends on who you marry, like, or have kids with, right? And so she's already thinking about like how many boxes they're gonna have to check,
Yeah.
right? All right, on page 18, the other racial and social equity measure is the number of equity lenses applied to performance improvement projects with data. And so for quarter 4 24, which is April or June 2024, 147 of the submitted PI projects or COAPI reports had these equity lenses. That's well above the target of 40. So we might need to revise that one as well. But for fiscal year 25 quarter 1, this is a partial 20 so far. It just kind of depends on when the reports are due and when their QAPI presentations happen. The nice thing is that we're seeing them become more sophisticated in the equity lenses that they're presenting, being able to speak to. And some of our facilities are actually putting a sustainability, like an environmental sustainability lens and a financial lens, like a ROI, under their PI projects as well. So the equity lens was the first one. Now we're getting additional lenses added.
Eric, can you add the percent for the report up? Because, you know, I don't know, 147 is probably out of, I'm guessing like, I don't know, 1,000? I don't know how many there are across the system. It's a lot.
Yeah. It's gone up a lot.
Yeah, hi.
It's about 67% now.
Oh, okay.
Yeah.
So
So
maybe
I
that,
have a great graph that I can give to the board that shows since 2020 this steep increase in the percentage.
but you can also, you know, you can just have number and then percent here. I mean, it's just,
Yep.
yeah. 60, that's great.
Yeah.
Yeah.
That's really good. See, I wouldn't know that. I would think, oh, 140, yeah. It's 10%. See, I did the math was wrong in my head.
Yeah. Okay, and then the last two slides, or three slides, is the dashboard in all its glory with the green, yellow, and red, as well as the glossary. And you see a lot of green. So just
Sorry, just on the equity thing again. It says the FY '24, sorry, right, FY '24 Q4 data is higher than typical due to Quality Academy completed projects. Is that a one-time thing or?
no. Hillary, you want to speak to that?
So we have a Quality Academy program, and the graduates from that program happen around May of every year. So because this time period is April, May, and June, it's always going to be more.
Oh, that quarter
Projects.
will always be inflated
Exactly. Yep.
relative to the other.
So in the next quarter, there will be less.
I see.
Yeah.
Okay. But I think to Shadi's point, the percentage is very informative.
Yep. Yeah, we can definitely add that.
Any other questions for us?
I have a couple of questions, comments. One, and they're very short. One is on my chart. I wonder whether there's a measure, we have 80% of people using it. And
Signed up for it,
so 450,000 patients we see in primary care, that's about 300,000 plus that are using it. So.
Could use it.
Signed
Or
up.
could use,
Could use it.
could use it.
Because that's where you're going.
Could use it, so, yeah, I mean, like, I think it would be, and you probably have the measure already, but I don't know. I'm not gonna sort out the measure now, but it's more like, is there a measure of how people use it, or how often they use it, or how
Right.
something, it could be one metric, it could be something like an index, but do you use it to communicate with your doctor, to set up appointments, to check your lab results? Maybe it's did you use it to do at least one of those activities? Something that tells that we can get people excited about, like, maybe something operationally that can make us better.
Yeah. No, I mean, this is something I think we discuss every quarter as
Right,
well.
I was
It's
gonna say.
how do we measure my chart utilization? The last time we looked at the Epic kind of standard metrics on it, none of them really spoke to us in terms of that truly captures utilization. And so we did charge our My Chart steering committee to come up with, for the next time that we change or we look at these metrics, we want a utilization number or metric. I don't know where we are on it yet, but I could definitely follow up. But
Seems
there's,
like it should be an or,
yeah,
right? That the category should be meaningful use.
yeah,
And then we all have meaningful use. So say, I check my labs, I don't have to ask my doctor a question, right? But that's meaningful to me, right? My doctor doesn't have to
Well,
call
even
me.
just login,
there's
yes.
there's
But,
was
well,
more like-
login they have, but the problem with the login is you have to ask yourself, how do you know that it was a meaningful?
Yeah.
So when I open a patient chart, I can see that they are enrolled in my chart, and I can see the most
time they-
recent time they logged on, which is helpful because if the last time was 2 years ago, I'm not gonna send them a message.
Yep.
Right. Well, if the last time was 2 days ago, I will, and Epic will tell me whether they read the message. and Epic will send me back a note if they don't read the message. So, but you would need some sort of meaningful
Yep.
use.
I think the Epic one, I mean, I probably have these numbers wrong. It was something like if they logged in 3 times in the last 6 months, it was considered they were active user. But if you go to your doctor once
Every
a
6
year,
months, why
right?
would you?
So for those reasons, we didn't love those. The one that a lot of systems use is, do providers respond to my chart messages within 48 hours, like that metric? Because the idea is that if you are responding to them, then they'll likely be using it. If you're not responding, then they're like, well, that was a waste of time for me to send that
But,
message.
you know, getting your medical records and
Yep.
reading your labs are very meaningful things to people that don't involve any messages. I mean, I find as a provider, the fact that my patients can read their labs so helpful. But that doesn't require that I answer anything.
Yeah, so that's why it's so hard to pick one. But I think we're gonna have to pick a less than perfect one, like a or, right?
But you know what you can also do just with the logins? You shouldn't use the number. You can actually just do a visual map. I mean, someone has to write the code, but you just look and say, okay, in the past year, all the people who registered, how many did they do? And you'll actually see there'll be, this group at the top that's like, like you can do it by day, and it becomes this really beautiful graph where you'll see like a high utilizer group, and then you're going to see everybody else, and it'll be like this, right? I mean, they can't. Come on, it's like they can figure out how to do this.
Yeah.
If I can tell you how to do it, they can figure it out. But like that would just tell you how many logins.
What would that show? You're just saying that they registered across the top and then if they've logged in?
No, so what you do is you show, it's like a frequency map where you'll say, okay, this is, it's day 1, days for 365, and you'll see these lines of like how many times people logged in. And then you just start to, you aggregate how many times people are falling into that. I can't explain it very well. I can show you what it looks like, but it basically gives you a sense of how people are concentrated in their use. You still won't know like
What they're
it
doing.
tied to like their number of visits, but if you look and you're like, wow, half the people are logging in, I don't know, I'm making it up. You can also see it over time because you'll see concentrations, right? Logins are very concentrated. So anyway, there's a million ways that they could do it. This is so interesting.
So, and I have
The My Chart
so-
steering committee.
Yeah.
one more comment and then,
Wait, before, so
Um,
Jose, you
yes.
said that 82% activations and then 447,000 primary care, but are there non-primary care activations? Are those?
There are, but the metric right now is changed to just be impaneled to H&H primary care.
I see.
Yeah.
So
Okay.
it
Just trying
used
to
to
focus
be
on that.
the universe, yeah.
Or you can get activated, like let's say you hadn't seen a primary care and you went to like cardiology referral, they can activate you there?
Oh, yeah.
Okay.
You don't have to.
Yeah, see, I'm a big PCP, I'm a big PCP person, so.
ED use,
Okay,
anybody can be activated.
okay.
and so this one is simpler. The, so when we go back and reconsider metrics at some point, and, which we do it periodically, like metrics that are like, sort of like, it went up, but that could be good, or it went, like they're ambiguous, we should probably just try to figure out like how to redefine it, or
add other-
check out what's the issue with the denominator, or take it out, or just because it's like, I look at it and I'm like, well, so then what do I do with this? And there were like 2 of them that we talked about today, so that's it.
The wellness encounters.
Yeah,
and the-
wellness and the,
And the NYC care could,
I mean, I think those are important things. to be
e-consults, we
tracking.
talked about it in e-consults,
yeah,
yeah.
yeah. Yeah,
I think they're important topics to track, it's just maybe those aren't right.
Just to think about the metrics, yeah.
Very good.
Okay, anything else?
Our last meeting with Eric.
Oh,
No, it's not.
And
No.
strategic
He's-
planning,
you'll be
He'll
around.
just be at other forums. He's
Yeah,
going to other forums.
yes,
but Eric,
thank you.
yeah, thank you so much.
yeah, yeah. Thank you,
Thank
Shadi, for
you.
bringing Kwapi to
You know,
Although I did,
12 years of Quappy has to give
Yeah.
me something.
yeah.
Any old or new business to come before the committee? Hearing none, the meeting is adjourned. Thank you so much.
Thank you.
This meeting is no longer being recorded.